Hello everyone and welcome back to another video. Now, before I go on, this may be a long video, so please use the timestamps in the description below. I may end up uploading parts of this video separately so it's more navigable. The purpose of this video is to explore two topical solutions that are commonly used to treat scalp and skin inflammatory conditions. These medications are Tacrolimus and Clobetasol. Now, DHT is implicated in scalp and skin conditions that are often related to inflammation. Aside from the obvious condition of androgenetic alopecia or male or female pattern hair loss, DHT has been found to contribute to conditions such as acne or acne vulgaris and seborrhoeic dermatitis. I'm going to be doing a review or some kind of literature review in this video, mainly to focus on how Tacrolimus and Clobetasol can help reduce scalp inflammation. Scalp inflammation may greatly reduce the efficacy of hair loss treatments because when the skin around the hair follicle is inflamed, conditions like telogen effluvium are likely to occur. Also, in general, inflamed skin does not promote healthy conditions for hair follicles to grow better hair. So the short-term use of Tacrolimus and Clobetasol may be warranted. That being said, please consult a healthcare professional such as your doctor, as these medications are prescribed and must be used under the supervision of a doctor. Remember, don't self-medicate in any way. So, without further ado, let's begin this video. I guess you can use this term when you're talking about more broader conditions that concern DHT, the umbrella term of DHT-mediated disorders. Now, this term encompasses a range of conditions primarily steered by the impact of dihydrotestosterone, or DHT, on specific tissues. DHT, a potent derivative of testosterone, is converted via the enzymatic action of 5-alpha reductase and has been implicated in various disorders, including several linked directly or indirectly to skin health. To give a brief overview of some DHT disorders, whether they're skin conditions or not, here is a brief list. Prostate issues, particularly benign prostatic hyperplasia or BPH, where DHT contributes to the enlargement of the prostate gland. Hirsutism, noted by the excess hair growth in women, often in areas like the chin and upper lip, are indicative of the hormonal implications of DHT in hair follicle stimulation outside of the scalp. We also have seborrhoeic dermatitis. I've talked about this a lot, but seborrhoeic dermatitis is a skin condition characterized by inflamed, oily skin, which is typically itchy, and sometimes presents with flaky skin on the scalp, as well as red patches. The role of DHT, while often discussed, may have indirect implications through sebaceous gland activity. That is, DHT tends to excite the sebaceous glands, which causes them to produce more sebum than usual. It is with this excess sebum that the pores and follicles become clogged, causing for specific bacteria and microorganisms to inflame the skin, and thus the condition of seborrhoeic dermatitis arises. And finally, a very popular one that many of you know, androgenetic alopecia, also known as male pattern baldness or female pattern baldness, or genetic hair loss, whereby a genetic sensitivity to the hormone DHT in scalp hair follicles results in their miniaturization and eventually a halt in hair production. Delving deeper into the impact of DHT on the skin, particularly in conditions like acne and seborrhoeic dermatitis, it's often observed that DHT plays a pivotal role in modulating sebaceous gland activity. In essence, DHT causes the sebaceous glands to overproduce oils that are rich in triglycerides and cholesterol, when typically these oils in their normal state contains specific nourishing components such as free fatty acids and squalene.
The dermatitis presents as scaly, sometimes oily, inflamed skin that can be itchy or even painful to touch. This is an inflammatory condition the cause of which is not well understood, although there does seem to be a genetic component in Caucasian, particularly of Celtic descent, are most susceptible. It seems that the sebaceous glands attached to the hair follicles begin to produce a very rich form of sebum. The sebum contains fewer free fatty acids and squalene but increased triglycerides and cholesterol. In part, the trigger for may be androgen steroids. Times of hormone fluctuation, such as during puberty, can activate the onset of seborrhoeic dermatitis,
And there's actually an interesting study that talks about this entire process. Consequently, these overactive sebaceous glands produce oils that, when not in balance, can create a conducive environment for clogging of the pores and skin sebaceous glands, thereby trapping bacteria. This scenario sets the stage for conditions like acne vulgaris, when this occurs on the facial skin, and potentially seborrhoeic dermatitis, when it occurs in the scalp. It's important to mention that the understanding of DHT's involvement and inflammatory interactions with the skin is derived from various scientific studies that explore the biological and clinical aspects of these conditions. These research endeavors examine the genetic dispositions, enzymatic activities, hormonal levels, and cellular responses related to DHT and its impact on skin and hair follicles. So now we're going to be geeking out and looking at various scientific studies. So the first, set of studies that we're going to be looking at concerns the topic of DHT and its effects on scalp and skin sebaceous glands, particularly the composition of overactive sebaceous gland sebum and suppressing sebaceous gland sebum activity. So let's get started with the first paper. Paper 1. In a pivotal study conducted by King et al. In 1982 titled, quote, "A double-blind study of the effects of 13-cis-retinoic acid on acne, sebum excretion rate, and microbial population," unquote, the impact of 13-cis-retinoic acid, commonly recognized as isotretinoin or isotret, and this is just Accutane, so just want to let you guys know, was investigated in the context of acne treatment and related physiological variables such as sebum excretion and microbial population on the skin. A particular focus of the study elucidated the intricate relationship between sebum, specifically its triglyceride content, and the proliferation of acne. King et al. Provided compelling evidence regarding how isotret plays a crucial role in reducing sebum excretion rate, and subsequently the microbial populations, particularly Propionibacterium, which are notably associated with lipid-rich areas of the skin. Triglycerides, a prominent component of the overactive sebum that causes acne, were highlighted as a significant factor for the growth of these microorganisms, suggesting that sebum, rich in triglycerides, contributes to the proliferation of acne by providing a conducive environment for the growth of propionibacteria. Thus, a reduction in sebum excretion rate, and therefore the availability of triglycerides, through the administration of isotret, also known as Accutane, indirectly limits a key nutrient factor for propionate bacteria, thereby reducing its populations and potentially mitigating acne severity. Now, this is a decently old study, pretty old study from the 1980s, and if you're watching this sometime in the future, I'm making this video in 2023. But it's well established, particularly from this study and other studies like it, that by modulating the sebaceous gland activity, we can reduce rates of acne proliferation. It's not to say that triglyceride content of the skin sebum is the only cause or the one and only cause when it comes to the proliferation of acne, but it's definitely a contributing factor. While it's well established that sebaceous gland activity in humans is androgen-mediated, as King et al. Continues to cite previous research done by Sansoni-Bazzano, Sealer, and Cummings, 1980, King et al. Emphasized that the isotretinoin does not function as an anti-androgen. Instead, it exerts its effects directly on the differentiation of the gland. This distinction illuminates the innovative therapeutic pathways through which isotretinoin, again being Accutane, impacts acne treatment, not by suppressing androgen activity, but through directly modulating the sebaceous gland's functionality and differentiation. So in conclusion, the study by King et al. Provided a multifaceted perspective on the role of isotretinoin in acne treatment, accentuating the impact on sebum production and microbial activity, and highlighting its unique action on sebaceous glands. Now, since this paper has been published in the 1980s, Accutane or isotret has become a popular course of action when it comes to addressing acne. This goes to show how fundamental this paper is when it comes to our understanding of how we can modulate the sebaceous gland activity, not by any sort of anti-androgen way, but just through manipulating the sebaceous glands. It also informs us of the potential components of bad sebum, or sebum that causes or contributes to these conditions of acne or seborrhoeic dermatitis, which we will be touching on shortly. In a 2007 article titled, quote, Pharmacological Modulation of Sebaceous Gland Activity, Mechanisms and Clinical Applications, unquote, Clark et al. Provide an extensive exploration of the intricate mechanisms underlying the pathogenesis of acne vulgaris and the pharmacological interventions available for its management. The authors elucidate the complexity of acne, a condition affecting nearly 85% of people between ages 12 and 24, as well as a significant number of adults, impacting up to 50 million people in the United States annually. At least back at the time this study was made. It probably is more or less the same right now. The authors delineate 4 primary pathogenic factors that drive the development of acne. Number 1 being that acne is largely androgen-mediated. There is an androgen-mediated stimulation of sebaceous gland activity, leading to sebum production. 2 being abnormal hyperkeratinization of follicles, resulting in follicular plugging and comedone formation. 3. The colonization of the pilosebaceous unit by the gram-positive bacterium, propionate bacterium, and finally, the stimulation of an inflammatory cascade and release of inflammatory mediators caused by the propionate bacterium into the follicle and surrounding skin. So basically, you have these bacteria that feed off of the excess sebum that get into the skin, and then it induces further inflammatory cascading events. And those inflammatory conditions can either be acne or acne vulgaris, and again, like I said, we'll touch on this later, but seborrhoeic dermatitis if it happens on the scalp. Anyway, going back to the paper brings a focus on the role of dihydrotestosterone, DHT, in the modulation of sebaceous gland activity. Clark et al. Shed light on how hormonal regulation, especially via DHT, influences sebaceous glands and holocrine sebum production. They detail the life cycle of sebaceous gland activity. Robust during the first 6 months of life, diminished post 6 months until puberty, then dramatically increasing and stabilizing throughout adulthood. The authors underscore the concept that the size and activity of these glands, which can increase with age, are likely hereditary traits. So genetics is something that you should definitely consider. So even if you're using something like a topical anti-androgen like Winlevi, to treat the DHT in your skin and reduce the presence of acne, or something like tretinoin or isotretinoin, you're still going to have an underlying genetic factor when it comes to your likelihood of getting acne or other sort of inflammatory skin conditions, especially when it directly relates to the sebaceous gland. Similar to what we looked at in the King et al. Paper, this article highlights the pharmacological agent isotretinoin as a potent modulator of the sebaceous gland activity, capable of reducing sebum production by up to 90% and subsequently inhibiting propionate bacterium acne's growth and inflammation. So if you can reduce the sebaceous gland's activity, you're reducing the presence of this bad sebum, right? And if you're reducing the presence of this bad sebum, the bacteria that feeds off of that bad sebum won't be in abundance. They'll eventually die off, and you'll be able to decrease the presence of acne and even other inflammatory skin conditions. Clark et al. Delve into isotretinoin's efficacy and application in various clinical scenarios, from its traditional use in severe recalcitrant nodulocystic acne to its application in moderate and moderately severe acne cases resistant to conventional therapies. They underscore isotretinoin's capability to influence 4 key pathogenic factors of acne, impacting the cell cycle progression, cell differentiation, cell survival, and cell apoptosis. Despite its efficacy in mitigating acne, the exact mechanisms of isotretinoin, especially regarding its interaction with DHT and sebaceous gland modulation, and whether they operate via the retinoic acid nuclear receptors or somehow interact with androgen receptors, is still an area that requires further research, but pretty much the scientific consensus is that isotret and other topical retinoids that are capable of impacting the sebaceous gland and reducing sebaceous gland activity seem to be operating via the retinoic acid nuclear receptors. So in summarizing the literature, Clark et al. Highlight the pivotal role that DHT has in the sebaceous gland activity and the consequential development of acne vulgaris and other inflammatory skin conditions. The exploration into the pharmacological strategies, particularly isotretinoin, provides insights into the complex interplay of hormonal, bacterial, and inflammatory factors in acne pathogenesis. This foundational knowledge catalyzes further research into understanding the nuanced mechanisms through which DHT and other factors like the genetics of someone's sebaceous glands, as well as potential agents that we can use to help treat these conditions. In the comprehensive review titled, quote, Regulation of Human Sebaceous Glands, unquote, by Dene Tibetot et al., published in 2004, the intricacies of sebaceous gland regulation and its pivotal role in acne pathogenesis were meticulously explored. The authors illuminated on the profound medical and psychological implications of acne, despite it not being a life-threatening condition, underscoring its capacity to inflict permanent scarring and triggering feelings of depression and anxiety, especially amongst adolescents. And guys, I can think of another condition that has a similar sort of, anxiety to it, and that would be androgenetic alopecia. So let's look at this. We're going to try to build up the case of how DHT is just a shit hormone that is not only making you bald, but could be giving you acne. Anyway, Tibetot et al. Succinctly elucidated the pathogenesis of acne, highlighting the essential role of sebum, a lipid-rich fluid, in facilitating the colonization of, you guessed it, that propionate bacterium. And this particular bacterium causes inflammatory responses in the skin. And remember when they mentioned that these inflammatory responses can cause permanent scarring? Well, I want to keep that in mind because, again, this is DHT's doing when it likes to hyper-excite the sebaceous glands to even cause this environment of skin inflammation to exist. It can lead to physical damage of the skin structure. And DHT, admittedly, is doing that to your scalp, especially when it comes to your hair follicles. But that's not necessarily the focus on this particular paper, but again, we'll touch on that later. But returning back to the paper, the authors begin delving into the morphogenesis of the sebaceous glands. Tibetot and colleagues expound on the developmental journey of these glands from hair follicles and emphasize the substantial variability in their size and distribution across different anatomical regions. The review also sheds light on the potential involvement of epidermal stem cells in the regeneration and functioning of the sebaceous glands. Interestingly, the authors noted the unique lipid composition of human sebum, which includes squalene and wax esters. And they explored how the sebaceous gland selectivity utilizes fatty acids for synthesizing these lipids. Tibetot et al. Underscored that certain fatty acids, such as palmitic acid, are preferentially incorporated into wax esters, while others, like phenolic acid, undergo beta oxidation, indicating a specialized metabolic pathway within sebaceous gland cells. So here we're having an understanding of what good sebum entails, and that is essentially having these fatty acids and squalene that is a nourishing kind of sebum. And also, as a side note, I think when people take Accutane, and heard of this many times, how Accutane has messed up people's sebaceous glands, maybe there could be some sort of condition after you taking Accutane that you're no longer able to produce that good sebum, the sebum rich in squalene and fatty acids. I just thought that was interesting to bring up. Certainly that probably would require its own video separate from this one. But going back to Tibetot et al., once again, like with the other papers, they talk about how isotretinoin or Accutane can be used to downregulate the sebaceous glands and treat acne. And once again, these authors also outlined the crucial role of androgens such as testosterone and more so DHT, dihydrotestosterone, in the physiological regulation of sebaceous glands and even the manifestation of acne, asserting that these hormones might act as a catalyst, augmenting sebum production and thus significantly contributing to the development of acne. The paper also extended to the local metabolism of androgens within sebaceous glands, elucidating how this local production might significantly influence sebum production and acne. So right here, guys, I guess we can all think of a local metabolism of androgens, and that would be testosterone interacting with 5-alpha reductase, turning into dihydrotestosterone. That is a metabolic process because you have this chemical compound testosterone interacting with an enzyme, turning into a new chemical compound being DHT, or hormone. And when you hear local metabolism, you can think of paracrine hormones because DHT is mostly produced at the site of certain tissues. That's why it's called a paracrine hormone. So I don't want to rage on what a paracrine hormone is, but you guys should probably Google that. That is paracrine, which is spelt P-A-R-A-C-R-I-N-E. So look it up, guys, and I hope you can find more about paracrine hormones, specifically DHT. So I hope you guys can see where I'm going with this, all of these papers trying to synthesize these ideas together. Because right now we have an understanding of what DHT and 5-alpha reductase cause the sebaceous glands to overproduce sebum. And in this overproduction of sebum, you're not getting sebum that has certain good qualities such as squalene and fatty acids. You're getting sebum that has high triglyceride and cholesterol content. And this sort of sebum that's rich in triglycerides and cholesterol is a breeding ground for a certain bacterium, propionate bacteria. And when this bacteria or bacteriums are in abundance, they cause for inflammatory skin conditions, whether it's acne, acne vulgaris, seborrhoeic dermatitis, and many other skin conditions. And here, there also is a genetic basis when it comes to your baseline sebum activity, the size of your sebaceous glands, and also how sensitive they are to DHT. And again, doesn't this remind you of another condition? That condition being androgenetic alopecia. Your hair follicles, all of them have their own sensitivity to DHT. So we're not done yet. We still have some other studies to look at, but I just want to bring that back in mind to everyone, that when you regulate DHT, you're also reducing the activity of the sebaceous gland. I think, did that just rhyme? When you regulate DHT, you also control the activity of the sebaceous glands. That's kind of funny. If you're listening right now, comment in the comment section bars. Rappers, when they're good at rapping and rhyming, they just say, yo, bars. That was corny anyway. But comment bars, B-A-R-S. But anyway, let's continue this video. Further evidence of DHT inflaming the sebaceous glands can be seen in the mechanism of action when it comes to Clascoterone, also known as CB0301, which is a topical anti-androgen used in the treatment against acne. It is sold under the brand name Winlevi. I've covered this study many times, but this is the study that actually got Clascoterone approved. This is the phase 3 clinical trials that got Clascoterone approved for acne, this topical anti-androgen. So in a pivotal study conducted by Herbert et al. 2022 entitled, quote, Efficacy and Safety of Topical Clascoterone Cream 1% for the Treatment in Patients with Facial Acne, 2 phase 3 randomized clinical trials, unquote. The authors delve into the potential benefits of using Clascoterone cream, 1%, to mitigate facial acne, emphasizing its role in inhibiting androgen receptors, particularly focusing on dihydrotestosterone, or DHT. Acne being one of the most prevalent skin conditions globally, if not skin diseases, it's technically a skin disease, has been notably linked to hormonal changes and specifically the role of DHT, a potent androgen that can significantly modulate the sebaceous glands to produce more sebum. And like I mentioned in the King et al., in the Clark et al. Papers, when DHT overexcites the sebaceous glands to produce too much sebum, the sebum that comes out is typically a breeding ground for these sort of propionate bacteria. But coming from this particular angle, by controlling DHT, Winlevi, Clascoterone or CB0301, is able to downregulate the sebaceous gland and reduce sebum. And by doing so, it decreases instances in which inflammatory pathways can come about in the skin. Herbert et al. Underscored that androgens such as DHT synthesize both systemically and locally within the body, bind to androgen receptors in sebocytes, and stimulate pathways that result in that high sebum production and also further inflammation to the skin. 2 very important aspects when it comes to acne pathogenesis. The authors pinpoint that Clascoterone, when applied topically, competes with DHT for binding to androgen receptors, thus inhibiting the downstream signaling of acnegenic pathways. This means it potentially stifles the transcription of androgen-responsive genes, particularly the genes that, in this case, when it comes to the sebaceous glands, producing sebum. So by outcompeting DHT to binding to the androgen receptors in the skin. This will inhibit sebum production and reduce activation of inflammatory pathways, thereby addressing two critical aspects when it comes to the development of acne. The findings from the 2 phase 3 trials demonstrated not only a significant improvement in efficacy witnessed through increased treatment success rates and reduction in both non-inflammatory and inflammatory lesion counts, but also showcased a favorable safety profile with mostly mild adverse events. Clascoterone cream 1% emerges as a novel therapeutic intervention, providing a topical modality to address the hormonal pathogenesis of acne without any systemic anti-androgen effects, offering an innovative and potentially vital alternative in the comprehensive management of acne, especially considering the topical androgen inhibition is suitable for both male and female patients. This could pave the way for future research and development in topical treatments targeting hormonal pathways in acne and potentially other skin conditions like androgenetic alopecia, hirsutism, and other sort of, I guess you can say, inflammatory skin conditions based in excessive sebum production and other androgen skin disorders, like seborrhoeic dermatitis. So now we have to look at the relationships between androgenetic alopecia and seborrhoeic dermatitis, as well as acne. I've gone on this study for many times. I've talked about this when it came to the whole DHT itch phenomenon. What could be that potential of a DHT itch is possibly due to the overproduction of sebum in sebaceous glands. And again, what could be causing the sebaceous glands to act like that? That would be dihydrotestosterone, or DHT. Well, in the study titled, quote, "The Annual Changes of Clinical Manifestation of Androgenetic Alopecia, Clinic in Korean Males and Females, an Outpatient-Based Study," unquote, by Woo Sung Jang et al., 2013, delves into the complex relationship between androgenetic alopecia and seborrhoeic dermatitis, revealing the latter as a notable associated condition in both male and female patients with androgenetic alopecia. Exploring this intricate play, seborrhoeic dermatitis emerges as a prominent condition that is often paired with androgenetic alopecia due to its characterization by inflammation and scaly patches on the scalp, potentially complicating or exasperating androgenetic alopecia's progression by further impacting hair follicles and overall scalp health. Insights from broader literature accentuates the shared pathophysiological mechanisms such as inflammatory pathways and microbial activities. Also intertwining with androgenetic alopecia and seborrhoeic dermatitis poses unique challenges and considerations in clinical management and treatment approaches. Thus, the confluence of androgenetic alopecia and seborrhoeic dermatitis necessitates an integrative clinical and research approach, focusing on exploring the mechanistic interactions and developing management strategies that holistically addresses both hair loss and scalp health. This ensures that the interventions for one do not inadvertently aggravate the other. Furthermore, the intricate relationship between these two conditions underscores the importance of patient education in setting realistic expectations regarding treatment outcomes and management strategies, fostering an inclusive understanding of both conditions and enhancing adherence to management protocols. So what did this particular study find? Well, it found that seborrhoeic dermatitis tended to be correlated or related to instances of androgenetic alopecia. And the underlying, I guess you can say, reasoning for that is due to both conditions having a fundamental basis in DHT's interaction with the androgen receptor. So in the case of seborrhoeic dermatitis, DHT likes to, again, excite the sebaceous glands in producing sebum that's rich in triglycerides and cholesterol. This specific sebum that is produced due to the overactivity of the sebaceous glands due to DHT interacting with those sebaceous glands causes for specific bacteria to fester, and when that bacteria comes in a large quantity, it induces inflammatory pathways on the skin. Now, if this happens on the face, you get acne, and if this happens on the scalp, you get seborrhoeic dermatitis, or that sort of DHT itch. But again, androgenetic alopecia has its basis in hair follicles being sensitive to DHT. So with that kind of knowledge, patients can, finally understand why they may be having a DHT itch. And, I hope physicians when a patient comes in with androgenetic alopecia and is also complaining about an itch, that these physicians, these dermatologists can inform their patients like, look, here are some things that we can do. Maybe we can possibly get Winlevi, put it on your scalp, that being that Clascoterone 1% cream. Maybe we can do that. Maybe we can also give you topical finasteride or oral finasteride or oral dutasteride or topical dutasteride, some sort of like one of those 5-alpha reductase inhibitors just to address your androgenetic alopecia. Maybe we can give you ketoconazole, right? Because that can also be used to treat that inflamed skin when it comes to seborrhoeic dermatitis or any other scalp condition that has inflammation in it. We have another study titled, quote, Androgenetic Alopecia in Adolescents, a report of 43 cases, unquote, published in 2006 by Byum, Jum, Kim et al. I'll just refer to this as Kim et al. So Kim et al. Embarked on a comprehensive exploration into the clinical manifestations and endocrine statuses of adolescents affected by androgenetic alopecia in Korea. It may seem like I'm repeating this over and over again, but we want to bring the focus on what androgenetic alopecia is. Androgenetic alopecia is that sensitivity to DHT. But people used to think that it only affects adults. There's like this conception that it can only affect adults. But intriguingly, it also manifests in adolescents as well. Kim et al. Illuminate the clinical characteristics and accompanying conditions of androgenetic alopecia within a 5-year clinical study involving 43 adolescent participants. Notably, the study identified a mean age of androgenetic alopecia onset being about 16.8 years, which is crazy because, I mean, you may know somebody in your life, or you may know a friend, or maybe some friend of a friend, or some sort of associate that is relatively young and very, very bald. One of the salient findings of the study involved the notable prevalence of a family history of androgenetic alopecia observed in a substantial 72.1% of adolescent cases, a figure that intriguingly surpasses the adult report ranges between 30.9% and 64.5%. This highlights a potentially more significant genetic predisposition in adolescents who are facing androgenetic alopecia, but this merits further exploration in future studies. Essentially, what's being said here is that the younger someone is who's facing androgenetic alopecia, the more likely it is that they have a close relative who also has androgenetic alopecia. But I guess that goes without saying, right? If you're going to bald, it's due to your genes. Your genes was passed on from someone, your father, hopefully, right? Someone in your family gave you those genes, and now you're having androgenetic alopecia. But anyway, I digress. When it comes to the realm of associated conditions, Kim et al. Found that 27.9% of the adolescents were subjected to experience seborrhoeic dermatitis. And this, out of all the conditions they looked at, this was the most prevalent condition accompanying androgenetic alopecia, followed by acne vulgaris, atopic dermatitis, which all of this delineates a pattern that provides a nuanced insight into the dermatological landscape of androgenetic alopecia in adolescents. I don't want to continue going on and on about this study, but it is showing us something very important here, that there is some sort of relational strength between these conditions, between all of these conditions, a good deal of these skin inflammatory conditions, and that is the sensitivity to DHT. Either the skin's androgen receptors sensitivity to DHT, or whatever that genetic encoding is for that particular individual when it comes to their sebaceous gland, and the hair follicle's genetic sensitivity to DHT, and whatever genetic encoding that individual has when it comes to androgenetic alopecia and hair loss. DHT, this largely useless hormone after puberty, causes a lot of these conditions, or makes these conditions even worse. Through a compilation of literature reviews, it becomes evident that dihydrotestosterone, or DHT, plays a pivotal role in numerous skin conditions and disorders. These are characterized by a primary genetic sensitivity at the skin's androgen receptor and glandular levels, as well as by inflammatory responses that cascade into damage to the skin structures in various forms, whether it's the literal epidermis of the skin or the hair follicles of the scalp. When examining androgenetic alopecia, particularly in instances where it's combined with conditions like seborrhoeic dermatitis, it is plausible to assert that androgenetic alopecia can be categorized as a skin disorder, or more severely, a skin disease. Now, while androgenetic alopecia is not necessarily life-threatening, like you're not going to die by being bald, you may die socially, like chicks may not want to be around you, you may not have options and shit like that, but it does involve the progressive destruction of skin structures, whether it's the epidermis or any sort of skin layer or hair follicles themselves. And without intervention to slow or halt down this process, it may culminate in a permanent loss of hair. Expounding on this, there's this sort of phenomenon that's reported on the internet, the DHT itch. This DHT itch can conceivably be associated with the overactivity of sebaceous glands, a condition incited by DHT's inflammatory effects on the skin. Initially, this may manifest as an oily scalp. A lot of people who talk about DHT itch complain about that oily scalp, the scalp being too oily. And again, that's due to the overactivation of the sebaceous gland, causing the sebaceous gland to produce more sebum. DHT is causing the sebaceous gland to be overactive. And if this isn't addressed on the scalp, it could progress into clogged pores and trapped bacteria, that propionate bacteria in the scalp, and this fosters the potential development of seborrhoeic dermatitis or other nasty inflammatory scalp skin conditions. And I have to say this, while DHT may not be identified as the primary cause, it is critical to acknowledge that elements which promote inflammation and clogged pores can contribute to skin conditions such as acne and seborrhoeic dermatitis. Like, for instance, if you're just rubbing oil, like greasy fat foods onto your face, and you're just not being a cleanly person, which happens time to time, maybe you sweat too much from working out, it happens, you know, this could also cause acne, or this could also cause your scalp developing seborrhoeic dermatitis or other inflammatory skin conditions. Like, what I'm saying is, aside from DHT, there are other causes that can, cause acne and can cause seborrhoeic dermatitis. But DHT in this context stands out as a significant contributory factor, warranting further exploration and management into the framework of skin health and disease prevention, which we saw with the invention and FDA approval of the topical anti-androgen in the treatment of acne being Clascoterone 1% cream, or the brand name Winlevi. So how can we treat inflammation of the scalp that's caused by either DHT-dependent or other inflammatory conditions? Inflammation can significantly impact efficacy of treatments like minoxidil, topical minoxidil, or even oral, as well as finasteride and dutasteride. Inflammation may cause the scalp skin to swell, which can prevent topical treatments from working effectively, whether you're using a topical anti-androgen like RU58841 or a growth stimulant like topical minoxidil or latanoprost. The general inflammatory condition of an inflamed scalp can dysregulate hair follicles and cause conditions like telogen effluvium, which can exacerbate androgenetic alopecia. So in the case of DHT inflammation and its effects on the skin and in general scalp inflammation conditions, what are some potential ways we can combat this issue? There are two topical treatments we can use. Of course, these are prescribed, so go talk to a doctor maybe, don't buy it from any shady online gray market pharmacy. But these topical medications are Tacrolimus and Clobetasol. Tacrolimus is a topical immunomodulating medication, meaning it modifies the immune response or functioning of the immune system as by way of antibody formation or the inhibition of white blood cell activity. It is often used in the treatment of eczema, atopic dermatitis, which is also called eczema, and is available in the form of an ointment. It works by suppressing the immune system's activity in the skin, thereby reducing inflammation and alleviating symptoms like itchiness, redness, and swelling. It's particularly noted for its efficacy in reducing inflammation without the concerning side effects of topical corticosteroids, such as skin thinning. However, it may still have side effects, and it's typically used when other treatments have failed or are not advised. So again, let me say this, do not go get this from some random, weird, third world pharmacy. Don't do that. Don't fucking risk that. Go to a dermatologist and check if you even need this. In most cases, when you ask the dermatologist, especially if you're here in the United States like I am, they'll just say, sure. I mean, you're having inflammation, I can see it. Why not? Let's try this. Let's see what happens. But moving on to clobetasol. Clobetasol is a highly potent topical corticosteroid. Now this could, cause that sort of skin thinning, right? But anyway, going on with its description, it's used to treat various skin conditions that are caused by an overactive immune system, like psoriasis, eczema, and allergic reactions as well. Clobetasol works by reducing the actions of chemicals in the body that cause inflammation, redness, and swelling. It is available in various forms, including creams, ointments, and even shampoos. And it's applied to the skin to alleviate symptoms such as pain, itchiness, redness, all that sort of horrible inflammatory skin conditions. Given its potency, though, clobetasol is typically prescribed for short-term use and under careful supervision of a doctor to minimize potential side effects such as skin thinning, stretch marks, and small cases systemic absorption, especially when used on a large surface area. So don't go applying this all over your body. That makes no sense. It should be targeted to the area of concern, whether it's one spot on your scalp or the entire scalp, not your whole fucking body. That would be kind of funny, but that would be not needed. Both of these medications, Tacrolimus and clobetasol, might be considered in scenarios where inflammation is impacting the scalp and potentially contributing to conditions like androgenetic alopecia. If you have severe inflammation, right, or just this never-ending itchiness and inflamed scalp, I would, if I were you, go to the dermatologist or doctor, your general practitioner or whatever you guys call it in the UK, and ask them, hey, what about clobetasol and tacrolimus? However, the exact application and utility, but again, you're always going to be at the discretion of what your doctor will approve. But it's always advisable to at least bring these things up to your doctor. And there are some studies that we can look at to see how effective these two medications are when it comes to the treatment of scalp inflammation. The study orchestrated by Orton et al. 2012 entitled, quote, Efficacious and Safe Management of Moderate to Severe Scalp Seborrhoeic Dermatitis using Clobetasol propionate shampoo 0.05% combined with ketoconazole shampoo 2%, unquote, provides pivotal insights into the complexities of managing seborrhoeic dermatitis. The researchers meticulously explored the efficacy of Clobetasol propionate in moderating the symptoms and severity of scalp seborrhoeic dermatitis, especially when paired with ketoconazole shampoo. The inflammatory condition seborrhoeic dermatitis, often linked with Malassezia yeast proliferation, impacts not only the scalp but other seborrhoeic zones of the body. So it could be under your armpit, it could even be on your face, anywhere where there's hair pretty much, but we're going to focus mostly on the scalp. Within the structured framework of this trial, Orton utilized a randomized investigatory blinded approach unfolding over 3 distinct 4-week phases to meticulously evaluate the efficacy and safety of employing clobetasol propionate in various regimens. Participants underwent treatment combinations of clobetasol propionate and ketoconazole shampoo in diverse frequencies and combinations to pinpoint the most efficacious treatment strategy. The study unmasked the apparent superiority of clobetasol propionate containing regimens over ketoconazole alone in mitigating overall disease severity, underlined by a statistical significance of p less than 0.05. Furthermore, combination therapies harmonizing the anti-inflammatory attributes of clobetasol propionate and the antifungal efficacy of ketoconazole not only alleviated overall disease, or that disease being seborrhoeic dermatitis severity, but also notably diminished each individual symptoms, providing a thorough therapeutic strategy. Particularly the regimen involving twice weekly clobetasol alternating with twice weekly ketoconazole not only showcased pronounced efficacy in the treatment phase, but also sustained its therapeutic efficacy during the maintenance phase, validating the sustained impact of this combination in managing moderate to severe scalp seborrhoeic dermatitis. So this study furnishes a robust foundation championing the incorporation of clobetasol propionate in therapeutic regimens when it comes to dealing with seborrhoeic dermatitis. So here you have ketoconazole shampoo being used to address that sort of yeast proliferation, and clobetasol propionate to treat the inflammation caused by whatever bacteria or whatever sort of microbe is inflaming the skin. So clobetasol is actively suppressing the inflammatory response, and ketoconazole is killing whatever germs that exist, if I were to, put it simply. And in theory, we could also use clobetasol to treat DHT's inflammatory effects on the sebaceous glands. So that's just something else to keep in your back pocket. But again, when it comes to clobetasol and Tacrolimus, which we will touch on shortly, we can't use these things in the long term. So it has to be used in short term, maybe spurts, and then something cyclical, like maybe you use it for 1 month, take 4 months off and use it again, or you only use it until the itchiness or seborrhoeic dermatitis goes away. Now, it is thought that the androgen receptor does play a role in other inflammatory skin conditions, including psoriasis. And there is some research on androgen receptor-mediated inhibition of cutaneous wound healing. Ashcroft and Mills, in their 2002 paper titled Androgen Receptor-Mediated Inhibition of Cutaneous Wound Healing, unquote, talk about the role of macrophages and how the androgen receptor expressed in macrophages, and you can think of these guys as little white blood cells, can upregulate the tumor necrosis factor alpha, or TNF-alpha, which is a critical cytokine when it comes to the body's immune system and inflammatory response. Essentially, they find that TNF-alpha and androgen receptors in the context of skin diseases like acne and psoriasis point to the interaction of androgen and androgen receptors causing for the inflammation to be worse when these sort of white blood cells come about. So it actually could potentially make the healing process of whatever the body is trying to heal or combat against when it comes to the inflammatory process, because remember, inflammation itself is sort of a healing process, but excess inflammation can lead to damage. And it appears that the androgen receptor can dysregulate the TNF-alpha and lead to persistent inflammation that, without any sort of intervention, can lead to skin lesions characteristic of conditions like psoriasis. So I'll actually put this study in the description below so you guys can look at it a bit more, but it is very intriguing. And I only mention this study due to its connection or its hinting at androgen receptors, DHT, or other androgens being associated in other inflammatory skin conditions, because right now I'm going to talk about another paper that involves clobetasol in the treatment against psoriasis or scalp psoriasis. So in the research titled, quote, a double-blind vehicle-controlled study of clobetasol propionate 0.05% scalp application in the treatment of moderate to severe scalp psoriasis, unquote, Olson et al. Rigorously examined the efficacy and safety of clobetasol propionate 0.05% in managing moderate to severe scalp psoriasis through a comprehensive double-blind vehicle-controlled parallel group study involving 378 patients. So that's a high N count or population count of patients. The conspicuous therapeutic efficacy of clobetasol propionate was underscored by 81% of participants experiencing a 50% or greater clearing of psoriasis, with 26% achieving complete clearance, juxtaposed to the substantially lower 22% and 1% in the vehicle group. And vehicle group is just a solution that has nothing in it, so it's the placebo. Despite its commendable tolerability, evidenced by minor local side effects such as burning or tingling, the modulations in cortisol levels in 13% of the participants in the active drug group, and that's the group that got the clobetasol, spotlight a potential systemic absorption concern. So we could see some sort of systemic availability of clobetasol. So clobetasol getting inside of the body, even though it's being applied topically. So we have to, be careful when we're using this kind of drug. And this should advocate for a sort of meticulous scrutiny and ongoing research into the long-term systemic impacts. That is, if we were to use clobetasol long term. While the study's ample sample size and meticulous methodology bolster its conclusions, the brevity of the study, or the period in which this study took place, constrains the comprehension of the long-term ramifications and sustained efficacy of clobetasol propionate, thereby accentuating a need for further investigations into its enduring impact, safety, and influence on the quality of life amidst diverse patient demographics and varying severities of scalp psoriasis. Thus, Olson et al. Established a foundational basis for ensuing studies probing the intricate application and potential implications of clobetasol propionate in dermatology, especially in the perpetual management of chronic dermal conditions such as scalp psoriasis or other scalp inflammatory conditions. So now moving on to Tacrolimus. Tacrolimus in the treatment of scalp inflammatory disorders like seborrhoeic dermatitis. So we're going to talk about a particular paper by Braza et al. Titled, quote, Tacrolimus 0.1% ointment for seborrhoeic dermatitis, an open-label pilot study, unquote. And this study illustrated a promising alternative treatment modality for seborrhoeic dermatitis using Tacrolimus 0.1% ointment. The author showcased not only the potential efficacy of this non-corticosteroid immunosuppression ointment in providing significant improvement in lesional erythema and scaling scores, but also its safety, revealing minimal and non-serious adverse events among participants. The promising results from Braza et al. 2003 offer an alternative pathway for managing seborrhoeic dermatitis, particularly considering the potential side effects related to the prolonged use of the conventional topical corticosteroids. Even clobetasol would fall into those corticosteroids. So in this case, tacrolimus may be a better long-term drug that we could use on our scalps if we want to avoid things like the thinning of skin and other sort of systemic side effects. While the study by Braza et al. 2003 provides a valuable insight into short-term tacrolimus use, it also underscores the necessity for further research, specifically through controlled and more extensive studies that might offer a comprehensive understanding of tacrolimus's long-term safety and efficacy in treating seborrhoeic dermatitis as well as other scalp inflammatory conditions. This is particularly relevant in light of the chronic nature of seborrhoeic dermatitis, which often necessitates ongoing management strategies and, as such, a deeper understanding of the long-term implications in this context is paramount. So going to the results of the study, we have this study being relatively small in its population count. So we have a total of 15 men and 1 woman, so 16 participants. Again, it is very small, so this is a limitation of the study, and it only goes on for about 6 weeks. So it is a pretty short study, very short term, and it's an uncontrolled trial of daily topical tacrolimus of 0.1% ointment. Now, admittedly, this is some of the weaker studies that I've presented during this video. I guess you can say lecture, whatever this is. But nevertheless, I'm here to present essentially what all of the literature that I've been able to find says about these two particular drugs, as well as the entirety of DHT related to inflammation and other sort of scalp inflammatory conditions, and how clobetasol and tacrolimus can be used to control those inflammatory conditions. So in this particular study, this small study, we can see that compared to baseline, seborrhoeic dermatitis was alleviated in the participants, and that the 0.1% ointment is somewhat efficacious in the short-term treatment of seborrhoeic dermatitis. But again, further controlled trials are warranted to determine its efficacy and safety for this common condition. So that was a lot to present. It's a lot to present in this particular video, just all this sort of, clinical evidence that we have at hand. In navigating the complex issues of scalp health and hair loss, particularly through the lens of inflammatory processes, the judicious application of tacrolimus and clobetasol can potentially carve out a viable path towards symptom management and possibly enhanced efficacy of topical stimulants like minoxidil and even latanoprost. Again, we're trying to just focus on the inflammatory effects of DHT. Now, realistically, you could just, use Winlevi to treat that sort of DHT-dependent inflammatory, skin that's going on in the scalp, or you could just treat seborrhoeic dermatitis or other skin inflammatory diseases after the fact. Drugs like tacrolimus and clobetasol need to be under the supervision, definitely under the supervision of a dermatologist or doctor, because yes, it can be used to treat that inflammation, but we need to be cautious in terms of any sort of other side effects. And personally, what I find to be, I guess, a bit worrying of the two is clobetasol, which is a pretty potent corticosteroid, and this can give rise to a plethora of side effects and complications. So prolonged application of this might lead to skin thinning, the development of stretch marks, systemic absorption leading to internal side effects, and potentially triggering or worsening of the skin condition. Also, your skin can become essentially reliant on corticosteroids, and if you withdraw from it, it could cause like a weird shedding and flaking of the skin. So you don't want to have some sort of a chronic suppression of the local immunity with either Clobetasol or Tacrolimus. So we can kind of avoid that by not going long term, and that duration needs to be determined by a medical practitioner. So honestly, I can see it being some sort of cyclical and short-term kind of use of these medications to treat a inflammatory skin condition. So maybe something could look like 1 month on and 5 months off, or you use it until the condition goes away, something like that. But in any case, at the end of the day, it's probably best to speak with your doctor. But yeah, I'm kind of getting tired of just talking over and over again. You guys can't see the number of takes that I needed to do, the amount of, interruptions that I've had. I'm kind of getting stressed out a bit in the voice. I've been talking too much, so I got my sparkling water here. But in any case, if you made it to the end of this video, please leave a comment in the comment section below saying blue star, just to change it up a bit. Because I've been talking a lot and I want to see if people actually got to the end of this video. So hopefully I can edit this in record time. And yeah, my takeaways essentially is this, right? My overall takeaways is this. Decreasing scalp DHT is just paramount overall for people who are sensitive to DHT and are facing androgenetic alopecia. And by you decreasing scalp DHT, you may even limit the whole DHT itch phenomenon. You may even limit seborrhoeic dermatitis from proliferating. So that's pretty much it for this video. So remember, if you got to the end of this video, comment blue star. And I do consultations now. I'll leave my consultation link in the description. So yeah, peace out guys, and I hope to see you in the next video. Bye.